Hello, everyone. Thank you for joining us in this lecture series. Today, we have the privilege to hear from Dr. Vishali Gupta, who is a esteemed member of the steering committee in Proton. Dr. Vishali is a professor of ophthalmology in retina and uveitis from the Advanced Eye Center at the Postgraduate Institute of Medical Education and Research, PGI, in Chandigarh, India. She's also a senior consultant ophthalmologist in the same center. She is the president for the International Uveitis Study Group, and she has held many important positions in the ophthalmology societies in India. We are so happy to have you here, Dr. Vishali, and to learn from you. So the stage is all yours.
Thank you. Thank you, Rupesh, William, Carlos, and the entire Proton team for being here this evening. So I'm going to talk something about wide field, imaging, which ultra wide field imaging, and the value of peripheral OCT in inflammatory pathology. So the most important thing is when we work in uveitis, it's important we all know, we are all experts here, that we navigate through the diagnostic maze. So it's very important if we have a focused approach. The more focused we are, the earlier we will get out of this maze. The less focused we are, the longer we will spend the time in maze, and many a times that will cost patient his or her vision. So what are the objectives? The main objective in uveitis, we all understand, is to make a specific diagnosis and to make it as early as we can. We need all the aids which can help in making the diagnosis, narrowing the differentials, and reducing lab dependence. So this is what we expect from our imaging. In short, when we are doing imaging, and especially when we are talking about ultra-wide field, it should make a difference. It's not just for fun that you are seeing a lattice clinically and then you do OCT through that lattice and it shows something. To me, that doesn't make a difference. So if we are doing it for uveitis, does it make a difference? So let's see here. The ultra-wide field, when we talk of multimodal imaging, it's actually a combination of color, autofluorescence, fluorescein angiography, ICG, and now the OCT. And if you see, all of them are quite essential in making the etiologic diagnosis so that your reliability on the labs is minimized. Now, I'll give you an example of this patient. This is a patient with retinal vasculitis. You have a look at the vasculitis. The ultra-wide field allows you a panoramic view. So one look at the image, you have certain things which come to your mind. The first thing is it looks occlusive. So once you talk of occlusive, my possibilities would be TB, sarcoid, or Behçet's. But especially in the left eye, you see there are few choroiditis patches. So the moment I see the choroiditis patches, Behçet's is kind of out, and the perivascular location of these patches, I am thinking more about TB than sarcoid. So what happens next? I am between TB and sarcoid. Just get the fundus autofluorescence. Now, this ultraviolet field autofluorescence shows lesions which are multiple at the level of RPE as well as the choroid level. They are both active as well as inactive. Now, the RPE involvement per se is a very important biomarker that the disease I'm dealing with is TB and not sarcoid. So the next is if I'm thinking of TB and it looks occlusive to me, I need to document any areas of capillary non-perfusion and if there is any new vascularization. And there you go. Ultra-wide field fluorescein angiography clearly shows you that the periphery has extensive areas of capillary non-perfusion. This is the angiogram of the right eye. You can see there is NVD, as well as the periphery is non-perfused, and something similar was in the left eye. So just the ultra wide field imaging, minimizes my labs. I'm just thinking of TB at this point of time. So I'll get very basic tests done to rule out TB. So in this patient, the test for TB came out to be positive. Patient received ATT, laser, anti-VEGF, as well as steroids. And if you see the angiogram in the left eye, this is what I was talking about. You see the lesions, which are like serpiginoid, along with capillary non-perfusion and vasculitis. This is, even without the labs, honestly, you know that you are dealing with TB. I give you another example. This is a 28-year-old, and she has bilateral, if you can see in the right eye, a patchy vasculitis. She has along the major vessels some patches of vasculitis. So as I mentioned, we are not seeing any choroiditis patches, but we do the autofluorescence. A normal autofluorescence, when I'm trying to differentiate between TB and sarcoid, normal is more in favor of sarcoid, RPE involvement more in favor of TB. So this one, I know I'm mostly dealing with sarcoid, so I go on to the next step. The next step is the fluorescein. Fluorescein shows this small leakage you can see along the major vessels. Occlusion is not as dominant on your face like you have in TB. You do not have choroiditis, and ICG shows these dark little spots in both the eyes, which are sarcoid granuloma. TB on wide field, uh, any ICG for that matter, would show choriocapillaries involvement. It does not show those round granulomas of sarcoid because sarcoid granulomas are typically stromal, deep embedded. So you see them as round little spots throughout. So it's a non-occlusive large vasculitis with granulomas on ICG sarcoid. Do I need any investigation? Maybe as a courtesy to the patient, or for myself, I want to confirm, but this imaging gives me enough confidence to make the diagnosis. There have been publications on ultrawide field comparing TB versus sarcoid, and ultrawide field imaging was found to provide additional information in 91% of the eyes, monitoring disease, influencing the management decisions, 45%, such as initiation of scatter laser for the periphery capillary non-perfusion and new vascularization in TB posterior uveitis, you get it from ultra-wide field imaging. So if we look at this chart, uh, when you're looking at the peripheral choroiditis scars out of 33, more likely to be seen in TB in 18 patients and 7 out of 14 in sarcoid. But the if those scars in the periphery are located, or their location is perivascular, that becomes very characteristic for TB. Peripheral leakage can be seen in both, but non-perfusion areas, again, you see much more commonly in TB than in sarcoid. So if you're looking at the ultra-wide field and you are seeing these features, you can, I don't say always, but many a times, you get a clue in which direction you are moving. Coming to a case report, now moving on to the second part of the story, like how about OCT? Because this is something which is new, which has come up. So is it doing any value addition if you are doing OCT in the periphery? This is a 26-year-old girl, complains of floaters and redness, has mild anterior uveitis. So if you see here, you see a peripheral lesion, uh, which is kind of retinochoroiditis, and you do see cryolysis arteriolitis. You see these vessels along with it. Now, this is the kind of the lesion, if you are just imaging the posterior pole and not paying attention to the periphery, you are likely to miss. So you look at it clinically. To me, it looks peripheral toxo. So do I need to confirm it? Well, before I actually, and we all know out here, and the work from Alejandra and many others has shown that toxoserology, is more of a customary rather than diagnostic, because the diagnostic is Goldman-Whitmer coefficient, which at least we do not do it as a routine, and I don't think anybody does. So we run OCT through the lesion. Now, what does this OCT show? It shows, actually, we start from the vitreous. It shows some cells in the vitreous, which honestly, clinically, I was not able to appreciate. It shows retinal layer hyperreflectivity with underlying choroidal thickening. And if we look at the character of the choroid, this is spindle shape or fusiform. Now, this kind of choroidal thickening has been described typically in toxoplasmosis. So, vitritis, retinal involvement with underlying choroidal involvement and fusiform. We also did fluorescein angiography, as you can see in the bottom panel. It showed a ring-shaped lesion on fluorescein angiography, and ICG showed these dark spots, which personally I don't think are very typical for toxo, but they have been reported in toxo. So based on these findings, the diagnosis of peripheral toxo was made, and I did not do any labs. The vision was 20/20, lesion was peripheral, so I decided to observe. Now that we have an objective measure of observation where we can monitor the lesion, I think we are more comfortable in observation and more confident of not treating. This is what happens to the patient over a period of time. As we see, the lesion healed, and this is the character of the healed lesion of toxo, which has been described by in this paper, and the images are mine. So I'm showing you the image, which showed a healed lesion, thickened and attached posterior hyaloid with retina RPE approximation, and this kind of gets hourglass configuration. You can also see that fusiform thickening of choroid is no longer there. So it's a kind of a natural healing process. We did not do anything, we just observed. Now, secondly, uh, I said about monitoring. So when we are monitoring, it's very important that we keep an eye, like what I call navigating monitoring challenges. Now, what happens? One of the major challenges that we face when we start treatment for infective uveitis is the paradoxical worsening. There could be aggravation of inflammation due to several procedures, like we do lasers, cryos, surgery. So, and many of these changes will happen in the periphery and not always in the posterior pole. So if you want to monitor response to therapy, you need to document the periphery. So in short, imaging the periphery should facilitate patient in improving, should facilitate physician in improving the patient care. And how? This is a case example. This is an example to show that it helps in detecting the retinal lesions in the periphery, especially in viral retinitis, because there's a lot of media haze. And most of our decision to treat in on are dependent on day-to-day monitoring and progression. And for that ultra-wide field, I personally find it very useful. Now, I'm going to show you an example of this case. It's a 46-year-old man, sudden decreased vision in the left eye. These pictures are not mine, they were taken elsewhere. So he comes to the doctor with the left eye decreased vision, and this is what he looked like. All uveitis workup was negative. He was started on oral steroids. There was no response, and I was told that patient has developed exudative detachment following treatment with steroids. So that is when I saw the patient. Now look at these pictures, which are done using the standard photography, conventional 50-degree, and also beautiful capture of the periphery. And then you go on to one single frame where you see the pathology in its entirety. What we realized was this was a peripheral active retinitis because exposure to steroids resulted probably in very rapid progression of the disease. There are yellow areas of retinitis all over with hemorrhages and retinal detachment. When I looked at this retinal detachment, and you can see there is a little break here, I knew I was probably dealing with Regardi and not with exudative detachment. But I wanted to buy some time. I wanted to give him some antiviral before actually taking for surgery. But within 72 hours, the Regardi, you can see the hyaloid is now detached, and there is a massive increase in the detachment which is going. I knew I had to go in early and did the vitrectomy, and this is post vitrectomy. So seeing the big picture on ultra-wide field is essential for monitoring therapeutic response. And you can see this is a patient at presentation. The middle picture is 3 days of IV acyclo where we knew the patient needed something additional. So patient received intravitreal foscarnate, and I'm jumping on to 5 weeks, but in my practice, I monitor it daily on ultra-wide field, these patients with ARM. The second condition, which actually monitoring the periphery is very important, is when I start my patients of serpiginous-like choroiditis on anti-TB treatment. Overlooking the periphery sometimes could be detrimental because the paradoxical worsening might be happening in the periphery. And if we do not take care of the disease at that point of time, it may progress and start involving the center and thus affecting, compromising on the vision. So let's see how it goes. We all understand serpiginous-like choroiditis could be caused by TB. We also know that it's an immune-mediated response, and when we add anti-TB drug, it just helps in reducing the recurrences. It really does not take care of the current episode. For the current episode, we need steroids. And what happens? Paradoxical worsening. So the top panel shows when we first reported paradoxical worsening, actually we called it continuous progression of TB serpiginous-like choroiditis after initiating anti-TB treatment. So using this image, we thought the incidence of paradoxical worsening was 14% after we start ATT. But subsequently, as you can see in the bottom panel, when we start monitoring these patients on ultra-wide field, we reported it was seen in as high as 37% of patients after we initiate ATT. That was because we were missing out on a peripheral lesion when we were not looking at the periphery. So this is how it typically works. This is a patient, right eye has serpiginous-like choroiditis, but let's talk about the left eye. The left eye here has just a lesion in the periphery, far extreme periphery. So this is TB SLC, upper nasal periphery. So patient received ATT and steroids because the opposite eye center was involved. After starting ATT, he had paradoxical worsening 2 weeks later. So we injected Dex implant in this eye. As you can see, the previous lesion in the upper nasal has increased, and there is a new lesion which has appeared nasally, just below the horizontal raphe. So we did inject Dex implant. The lesions responded, ATT completed, no recurrence on 3 years follow-up. Vision maintained at 2020 because we were able to monitor the periphery. We were able to take action, which did not allow the disease to, come in the posterior pole that might have compromised his vision. Something else I would also mention that many a times patient of uveitis, we do laser, we do cryo, we do so many things. There is worsening of inflammation, but that worsening may be happening in the periphery. And I think it's very important to be very careful before doing any intervention. I'll show you an example. Now, this is a patient of Behçet's who's being treated on DMRDs because she couldn't afford biologics. So this was the right eye when we saw her. I did the angiogram. Angiogram showed extensive areas of capillary non-perfusion. Laser was done. And the next day after laser, I was like, oh, wow, what has happened? So you can see there are laser scars which are white, which are whiter than usual. I mean, I would not have done such intense laser. My fellow did. But besides those laser scars, you can also see retinitis lesions which have now appeared all over. We did report it as an ocular pathology, but that's not the aim I'm showing you. Why I'm showing you this slide is that if you see carefully, the top panel, there were probably small little patches of retinitis in the periphery, which I did not pay attention to. I was so looking at, to me, it looked quiet. And in fluorescent capillary non-perfusion was so overwhelming to me. I thought, okay, like, let's laser it. But probably if you see these patches, even in the periphery, it's better not to intervene at that point till the time you have inflammation totally under control. Monitoring not only of Behçet's and TB, but lesions like syphilis. For example, this is a patient with syphilis, penicillin is administered, and we all know that we typically do not give steroids to every patient of syphilis, unlike TB. But then patients with syphilis too are known to have Harish hexamer reaction, which this patient had. Then we added steroids, and this is how patient responded to steroids and benzathine penicillin. Monitoring overall gives you an idea what is happening. The third role which a peripheral imaging can play is in unmasking uveitis. We all understand there are dangers of misdiagnosis as well as dangers of overtreatment. So, how do we make the wrong diagnosis? We don't make it intentionally, but many infections, non-infections, and malignancies can mimic uveitis, and they all have more or less similar clinical picture. So this may lead to unnecessary treatment with steroids and DMARDs. In short, sometimes if you're careful, imaging the periphery may give you some clue which could save the patient from overtreatment. This is a case report where ultraviolet wide field helped us in making the definitive diagnosis and avoiding unnecessary therapy. Now, this is a male, and I have shown it quite a few times, so maybe you have seen it earlier also. A patient of intermediate uveitis. He has received methotrexate for 1 year, shifted to MMF, corticosteroids, so nearly 2 years of DMRDs, and no response. He had also received local steroid injections, but the macular edema kept coming back. So he was referred to me for initiating biologics. So I did the examination and I thought, well, intermediate uveitis. Till the time we saw these settle-like lesions in the nasal periphery, as is indicated by arrowhead. It was actually a case of caterpillar hair falling in the eye. We took the history, patient gave a history that 2 years ago he was on a motorcycle when caterpillar hair went into his eye. Some surgeon removed it from the cornea, but after that, he said the inflammation of the eye started in the same eye a month later and has been persisting still since then. But nobody paid attention to these. So that's the importance of clinical exam. And this is just to, confirm that what I'm talking is actually true. There were, I did the surgery for him. He had cataract also. So first we removed the cataract and then, as you can see, uh, cleared the vitreous, which had few debris. And most of these here are located in the periphery. So you can see this one here. It has got the vitreous opacification around it. Was easy to cut it with the cutter. There was another one which was sitting on the surface of the retina, this one, and it was kind of in the base. You can see the oracerate out there. So I had to tease it out with the forceps and remove it. But the moral of the story is that after removing it, patient was off all treatment, and now I have about 5 years follow-up on him. No DMARDs, nothing, just you take care of the etiology because of a good examination of periphery. Another example of a 6-year-old who came with blurred vision in the right eye. So the question is, like, something in the nasal periphery, as you can see with the arrowhead, what is it? Is it retinitis or choroiditis? Because it's a kind of strange looking lesion to me. She was carrying, the child's parents were carrying tests, and like in India, we test everything for TB. So TB were positive. So she was advised to receive anti-TB drug, and that's how the child came to me for a second opinion. Child was brought to me, not came to me. So when I did the OCT through this lesion, I realized there were cells in the vitreous with few membranes. Now look at the character of the cells. They're very different from what you see in toxo. There was no active retinitis and no involvement of the choroid. Now, what would produce an inflammation, a localized inflammation in the vitreous? I thought maybe it was kind of endophthalmitis endogenous, which was responding to therapy. So I took a history. There was history of fever with UTI. She was hospitalized, received IV fluid and antibiotics. So I did not investigate further. Provisionally, I put a diagnosis of mild form of endogenous endophthalmitis, which probably was responding to systemic antibiotics. Discussed with the patient, and I just decided to follow up. So, and of course, the decision not to start anti-TB therapy was purely based on the confidence which peripheral OCT gave me and the imaging that this is not choroiditis or retinitis. And since it's a child, I did not even have to do fluoresceins and ICGs because I could get the information that I wanted based on the OCT. So you can see this is over follow-up. You can see clinically that lesion has kind of really faded away, and OCT also shows that the number of the cells in this thing is much less and the patient has spontaneously resolved. Another patient, a 32-year-old male, referred as a case of viral retinitis for getting antiviral therapy. Now you look in one go, there is, of course, something retinochoroiditis in the posterior pole, there is fluid, and there is posterior hypopyon. Why should a patient of viral retinitis have posterior hypopyon? It's not very common. So, is it only retinitis or is it endophthalmitis we are dealing with? So, I do the OCT, and OCT shows rain cloud sign, which is suggestive of endogenous ENDOF. And then the history shows that, well, he was actually an IV drug abuser, and this is how, like I just did vitrectomy, and this is intravitreal antibiotics. Many a times, this I'm sure all of you experience that patients with multiple other conditions are misdiagnosed as uveitis and they are started on treatment which is not required. For example, PPCRA. Now here, wide field angiography in one go just shows you what you need to see. Now, coming to the last leg of my talk, this is another case example of a 28-year-old male who comes to us with complaints of floaters and low vision. Being treated as retinal vasculitis elsewhere, vision is 624. There are no cells, very few vitreous cells. Now you look at the overall appearance, both on autofluorescence as well as the fundus photograph. Now this shows ultra-wide field fundus picture shows optic head astrocytoma, which you can see nasally, seen nicely on autofluorescence. There are diffuse pigmentary changes, including bony spicules, but you will also notice there is periarteriolar sparing, which is very characteristically seen on fundus autofluorescence. This is the left eye, which again shows optic nerve head astrocytoma, lower nasal quadrant, and the nasal you can see beautifully, diffuse pigmentary changes, and periarteriolar sparing, which again appreciate better on FAF. Whenever I see so much symmetry, it always bothers me and gives me an indication that probably what I'm seeing is not uveitis. This one typically did not look like uveitis, but he was being treated as uveitis because of the presence of vitreous cells. It is actually CRB1 mutation associated with Leber's congenital amaurosis and the typical presentation periarteriolar sparing. We all understand that uh, vitreous cells can be there hanging in there in IRBs. So it's very important. So when we have the entire picture taken in one go, it's good. I'm not saying it's essential, but it's desirable. Another example, a 43-year-old female, decreased vision, both eyes. Right eye, she says recent onset, left eye, 10 years. She was being treated as serpiginous choroiditis on oral, not or, oral, and oral steroids. And vision was 618 both eyes. There were no cells. And this is what she was. Is it serpiginous? Not really, because it's too symmetrical again. You have mirror images in both the eyes. Inflammation doesn't cause mirror imaging. So this is actually Stevenson chorioretinal atrophy, which is also called helicoid peripapillary chorioretinal degeneration. And she was taken off all the steroids and treated. The fourth role, which ultraviolet field should help and does help, is in enhancing treatment. That is, adding the adjunct local therapies in uveitis management. Because we do understand that many a times patients on systemic therapy are doing, asymmetrically well. What I mean is, many a times you realize one eye is responding to systemic therapy, the other eye is not responding or needs little bit of local addition to it. I find ultra wide field very helpful in making that decision when I want to enhance my therapy. Now, this is an example of a 28-year-old whose TB test positive, quantiferon positive, receiving anti-TB drugs, and you can see the way the patient has started progressing. Paradoxical worsening, but really bad paradoxical worsening, which we were not able to control with systemic steroids. Now, when we do ultra wide field OCT, I will go back here. So till third picture, we were managing, but when he was lost to follow up, and when he came, his lesion here, you can see it has extended close to the fovea. When we did OCT, it shows an underlying choroidal granuloma. So this bump in the choroid is important because this indicates that probably whatever TB treatment we were giving is not working. So we did add adjunct therapy, which was host-directed therapy in the form of intravitreal anti-VEGF and moxiflox. And you can see the lesion over a period of time starting respond. And this is the last follow-up where he responded to additional injections of therapy. This picture on the left is before we gave, and the picture on the right is after receiving 3 injections of intravitreal ranibizumab and moxiflox 4 weeks later. ATT is continued, and we did not interfere with the systemic therapy because he had other eye also involved. We just added local therapy to it. And the last, number 5, utility of ultra wide field. We all understand not all uveitis requires treatment, and some lesions can be observed. I already showed an example of peripheral toxo. Lesions like that, we have always been observing. Ultra-wide field just gives us an objective monitoring tool. 12-year-old floaters, 20/20 vision, anterior segment quiet, and in the fundus, we see in the lower temporal quadrant, we see something which looks like toxo. And this is what the fluorescein shows, lesions suggestive of toxo. OCT again shows those cells, hyaloid, hyaloid with round cells, retinitis, hyperreflective, and fusiform choroidal involvement. Again, very classically, toxo, no labs, no investigations. And this is how 3 weeks later, Vision 2020, no choroidal involvement. It spontaneously resolved, few cells hanging in there, but I will not really either give intravitreal Clinda or even systemic therapy if the vision is good and I have a confidence of monitoring it objectively and showing that it is on the way to natural resolution. So recently, many of you are aware we have come up with, not come up with, will be coming up with MOVE guidelines, which are imaging-based guidelines by IUSG as a sequel to SUN 2, showing the imaging characteristic. There also, this is picture courtesy of Sapna, the MOVE task force showed that ultra-wide field FAF was very important to detect relapses in multifocal choroiditis. As you can see, the arrowhead indicates the development of new lesions in the periphery, while the posterior pole is by and large normal. MOVE task force also recommended wide-field ICGA for peripheral lesions in birdshot, multifocal, as well as amp. So I'm not going to get into details because you will see them subsequently. So to conclude, ultraviolet field helps in achieving all the five major goals of uveitis. The first one is navigating the diagnostic maze. It helps in minimizing the labs or at least giving a focused approach to do only the essential labs. Secondly, it helps in keeping an eye, that is, navigating monitoring challenges, paradoxical worsening, unlike lesions progressing, Harish eczema reaction. So it helps to know the periphery. Thirdly, it helps in unmasking the uveitis. It prevent by, you know, uh, you can minimize the dangers of misdiagnosis or overtreatment if you are looking into the periphery. For example, the caterpillar here. He was being overtreated because nobody paid attention to the extreme periphery. Ultraviolet field also helps in enhancing treatment. um, I gave an example of a patient who had worsening of the lesions, and the OCT showed that there was a granuloma. So there was role of adjunct local therapy whenever there is peripheral worsening. And the fifth was not all uveitis requires treatment. Rupesh and Jim are doing a beautiful study, and Carlos and William have spent a lot of time on revise, which is retinal vasculitis. And one of the working hypotheses that they have is probably all the peripheral vasculitis does not need to be treated. We are waiting for all that data to come out of Proton because I think ultra wide field is absolutely brilliant, but probably we are seeing so many things which we were not used to of seeing that we need to take a breath and not start treating everything that we are seeing. So personally, I'm looking forward to that results from Proton and Revise to show us that, no, I'm not going to talk, to show us that whether all the things which we are seeing in the periphery, are they all meaningful or not? So I'm sure they have uploaded ultra wide field images for retinal vasculitis, and I personally would be very interested in that subset of patients. Thank you very much, Team Proton, for the opportunity once again.
Thank you very much, Dr. Bishali. Um, is there any question from the attendees?
Thanks, Dr. Vishali. And I invite attendees to switch on their video. And therefore, we kept 15 minutes for interaction. So anyone, Padma Malini, Dr. Ho, Dr. JB sir, Dr. Anju.
I do
Sir.
have a question.
Yeah.
Yes, sure.
How did you used to deal with all these cases before the ultra wide field imaging?
We used to deal with them earlier also, and majority of us are dealing with them still because you don't have ultra wide field. And to be very honest with you, if I see 100 patients in the clinic, 80 of them do not require ultra wide field. It's
Mhm.
only those 20 which have a lesion where you want to do OCT through that. But I don't think we were mismanaging without it. It's just for the sake of talk, I'm showing all that. But in reality, I do ultra wide field, ICG, and fluorescein for my vasculitis patient because I want to don't miss out on the capillary non-perfusion. But before when we did not have ultra wide field, we used to move the camera to capture the 7 field as much peripheral as we can go. And then on spectralis, we had Storangi lens. You put a lens, it gives a wider view. So we were doing things at best, which we could do at that point of time.
I got it.
That's good. Dr. JB sir, do you do ultra wide field imaging in all your patients, or how many patients, or what patients you send them for ultra wide field imaging?
All EELS patients gets ultrawide field imaging. All my EELS patients gets ultrawide field imaging. This is a protocol with the fluorescent angiogram. We miss a lot of things.
If you don't do ultrawide imaging,
Yes.
I agree.
EELS or tubercular retinal vascular is a must.
And
We miss
Dr.
something.
Padma,
Yes, ma'am, very nice lecture.
Thank you.
We learned a lot. Yes, ultrawide field definitely changes the management, especially peripheral retinal pathology and retinal vasculitis. Ma'am, I would like to ask, sometimes we do get peripheral retinal hyperfluorescence without the CNP areas. So how do we differentiate the normal peripheral retinal hyperfluorescence with pathological one?
Yeah, that is the problem. That is what I want Revise to give us an answer. You know, uh, because when you see the periphery, you do realize they're trying to differentiate something called vasculopathy from vasculitis. So even a break in the barrier due to pressure changes, mechanistics, could produce a fern-like leak, what you are telling in the periphery. So there was a phase when we all got so excited looking at it that people started describing that there is peripheral vasculitis in HLA-B27, there is peripheral vasculitis in JIA, and we started giving them systemic therapies and all that stuff. I don't think that was the right thing to do.
Yes.
I think some of it was purely mechanistic and not inflammatory. If I have a situation like this, I look at cystoid macular edema and other signs of inflammation. If I do not find those, and there is just the fluorescein angiographic leak, I will not either start or increase my immunosuppression based on that. There was a phase when I used to do angiogram, and if that peripheral fern was there, I will not stop immunosuppression. But now I think I'm learning not to pay too much attention to that.
It
And
doesn't go up.
that is the entire Revise group is here. That is what I personally, if one question they can answer, that would be a great service to overall our patients, because we will avoid a lot of over treatment with the drugs which are dangerous.
so Dr. Vishali, thanks. Always enjoy your talk. There are certain questions which I have in mind, and which might be probably these are some of the audience who will be benefited as well. I was thinking, which are the patients coming to a uveitis clinic? We should be very keen about getting a ultra wide field imaging, maybe one or two, three things. And if you don't have in your center, for example, I should be keen. Let's say there is one patient right now in Nagpur. They don't have ultra wide field imaging. I'm arranging them to go to either Shankar Netralaya Chennai or Hyderabad, LVPI. So tomorrow the patient is visiting Mudit to get ultra wide field imaging for his retinal vasculitis, I'm suspecting. So do you have certain things where we should not compromise and we should definitely try and do?
I
So,
think Dr. JB already said that any patient with TB-like lesions, vasculitis, there, if we miss the periphery, we might end up with vitreous hemorrhage, what we used to call Eels disease. But now with ultrawide field, we see them very early, we treat them early, so we do not end up to a stage where they develop into vitreous hemorrhage. So that will be, if you ask me, that will be my only indication where I would like to do.
yeah.
The
So,
rest of the things which I said, like on and others, we
yeah.
were monitoring them even before, ultra wide field. It's just that ultra wide field gives more objectivity, but it's not essential to monitor. You can do it clinically with the help of diagrams also.
And second is the role of ultra wide field FFA or FA in the patients with macular edema. Let's say you got a patient with macular edema and periphery vision is 6/6, and the periphery, you don't see any evidence of retinal vasculitis. You think probably there can be there, and you're trying to do. So do you think it will be, because sometimes if you do a simple standard FA, you might not get anything, and then you do not know whether there was actually periphery.
Absolutely.
What do you?
Especially in patients like Behçet's and all. I ultraviolet field is extremely useful because you know what is happening all over the periphery.
Yeah.
So some of the complicated cases, yes, it
Yeah.
has helped us, and especially when you want to make a decision about stopping the therapy. I
Yeah.
want to make sure that I'm examining. I also find it very useful in my children with blouse and tinu and all that who have the peripheral leak, who have lot of fern like capillary leakage. I monitor all of them because they are on biologics.
Mm.
So before I increase the interval or try to stop biologics, I always get it done to get the complete view.
Thanks. Welcome, John, on call, and welcome, Professor Alexandra. So my second follow-up question on that of now this is not the our company or any kind of a talk related to any particular. Just let's say if I have Heidelberg, I try to use Heidelberg for wide field imaging, not really the ultra wide field. We don't have Optos here in my center. So is that enough? Because we ordered a wide angle imaging with Heidelberg, and most of the time we get it enough. And Optos versus Heidelberg, let's say for wide field. What do you
I
think?
think Optos does have some advantages. One is you don't have to put the additional lens and it is in one go. It's very comfortable for the patient that in one go you can capture. Uh, and other than that, it's 200 plus 200 degree.
Get more.
Even by putting the wide field on spectralis, you go up to 120 degree. You don't go up to 200.
Correct.
Now, whether that 200 is really essential or not, nobody knows. Rima had done a study comparing these two
Oh,
for
very good.
uveitis, and I don't think she found any difference. I
Okay.
think the practical information which we do not need ultra wide field, but when you are giving a talk, it looks beautiful.
And then a follow-up third question is how frequently angiogram being an invasive means it's not just for ultra wide field, but otherwise, do we need to repeat that test every 3 months, 6 months, 1 year kind of thing? Because sometimes because Optos, the OCTA is not able to kind of show the activity. So what do you think is a good protocol for us to follow? Let's say we did it at a baseline. How should we repeat it? How frequently or something? Is there any guidelines? I know there are no specific, but just wanted to understand.
When we talk about, we have to look at the indirect evidence of inflammation. For example, initially I do fluorescein done to look for the signs of activity, you know, whether it is vasculitis or it is choroiditis or whatever. Mainly, I want to know the extent of the disease, extent of the inflammation, and to make the diagnosis. Now, I do not need to repeat angiograms at every visit to monitor the response because my response can be monitored based on the OCT, based on the cells in the vitreous, uh, whether there is a coexistent macular edema or not. That gives me fair enough indication whether the vasculitis is active or not. In the late phase, in the very late phase, maybe after 8, 10 months, or maybe after 1.5 years, when I have decided that patient has remained quiet for very long, and this is the time for me now to stop or taper my immunosuppression. That is when I repeat it to make sure that there is nothing happening subclinically.
Absolutely. Yeah. So I think I do the same thing as well. Before stopping, I take a call, and if there is still leakage, then I continue with the thing. You know, I think that John or Professor Alexandra, any specific comment on the wide angle imaging in uveitis? You have any questions, comments, or any advice for any one of us?
I have done ultra wide field imaging every 6 months for EELS patients.
Oh, okay. That's nice.
So I find it's even if I clinically see that it's healed, there is some focus of neovascularization within between the laser photocoagulation marks. I've seen it. So I learned by mistake, and I do it. Protocol is 6 months.
Okay. Thank you, sir. John, you're saying something?
We have a Claris camera, not a Optos camera, so it's sort of intermediate. I think it's like 140 or 150 degrees. And it's rather nice, I think, because of the real color aspect of it, but it definitely doesn't reach as far as the Optos, but maybe a little bit past the equator. And we find that works, a lot better than it seems much easier than the Heidelberg with the big one. And so we mostly have been using that. I think we would use an Optos if we had it. So, yeah.
Yeah. No, been trying to arrange that Remedio wide field. I don't know whether they have come out with that. Dr. Vishali, I don't know whether you know about that. Remedio is trying to come out with a wide angle imaging, at least the fundus camera. Waiting for it. Have you got it with you?
Even for us, no, we
For us
have,
also.
yeah,
Yeah.
we don't spend money from our pockets, so we buy.
No, we are trying to get one for John there in the center, but we'll see how it goes. Any other
Yeah.
comments from anyone on the call? Dr. Christine, Dr. Camilo, Dr. Padma, Dr. Chitranjan, you've been doing good work there in Odisha, in Sambalpur. No.
Yes, sir. Sir, actually, a very nice talk. I must thank Vishali madam for the talk and to you for arranging this. I have only one question regarding the intravitreal anti-VEGF plus moxifloxacin madam told. That seems to be a very promising thing, and I think the J.M. Pahwa Award Dr. Manisha madam got this time, joined with one ROP talk by Akash. So that was also based on this treatment, like moxi plus anti-VEGF. Can madam tell something more about that treatment? Vishali madam.
That is kind of something which Manisha has described. It's a host-directed therapy because TB granulomas grow and they need VEGF to grow. So if you cut off the VEGF supply, they shrink on their own. So that is why it began with anti-VEGF. And then Manisha sees a lot of granulomas because of the pocket of patients there. And she showed when she added moxiflox to it, because fluoroquinolones do have anti-TB properties. So when she added moxiflox to it, there was a better resolution. And she's now randomized them into 2 groups and she's measured VEGF levels and all. We do not personally in Chandigarh see so many granulomas, but I find this useful, combining this therapy helps in the reduction of granuloma size very fast. So I added to the to the systemic anti-TB treatment.
Dr. Vishali, there is one call. Just to mention about Chitranjan, he has probably the maximum number of front page images on ophthalmology from his center. He has maximum record 30 plus images. So have you published any wide angle imaging? Then you should publish on wide angle imaging in uveitis on the front page of ophthalmology. Chitranjan?
Next. Actually, this January 2025 is going to be again ophthalmology retina hour, so that will make our number to 31. You are correct. So most of the images are from Claros actually. Ultrawide field, both Claros and Optos qualify for ultrawide field. So it is Optos less often and Claros most often.
Fantastic.
And Montas, like I said, one Montas with you, because currently where I'm working, we don't have ultra wide field over here in Tirulun Sambalpur. But during my Arvind tenure, we had access to Optos and Claros. So there we were doing these things.
Now keep up that good work, and you can contribute to Dr. Vishali's class on the imaging thing on uveitis probably.
Great.
So, Dr. Vishali, there is one question from our research assistant, Dr. Deepa, when using ultra-wide field imaging for children compared to adults with retinal disease. So, children, what is the wide field? What is the role of ultra-wide field?
Children, I always do because it's easier to do. With the conventional camera, moving here and there becomes very difficult. It doesn't have flash. So it's comfortable. Optos to all SLO systems won't have, but this is comfortable because in one go, you can just take the picture and children, I find it very useful. And many children, I don't label the patient as JIA. If the patient is having vitreous cells, I always get the fluorescein done. If the fluorescein, you will be surprised. Quite a few of children have fern-like capillary leak.
Yeah.
And when I see that, I do not automatically make a diagnosis of JIA. I ask them the history of taking analgesics in the recent past. I always get beta-2 microglobulins done, serum as well as urine, and you'll be surprised that many patients are actually TINU, which we label. And the second thing is, if you are seeing very aggressive leakage in both the eyes, always rule out Blau, because JIA-like picture with vasculitis, it is likely to be Blau and not JIA. I do not believe in the publications that say that JIA has posterior segment involvement. The vascular leak in a patient with JIA, I would look for other etiologies.
I think this is very important point, and I was just noting it down for one of the child I'm managing, of 17-year-old. So I'm going to kind of order. I was just messaging Rachel about ordering the test related to TINU. I'm going to do that immediately.
Many of them actually are HLA-DR B1 positive, so they do not have the complete TINU, but it's a kind of variant of there. So they respond very well to methotrexate.
Yeah.
You do not need biologics for them mostly, unlike Blau, where you need biologics.
So instead of azathioprine, you will suggest methotrexate. I'm on azathioprine on that patient, but if switching to
whatever, they do not need biologics.
Okay, they do not need that. Fantastic. Anyway, I think over to William. I think we are just 1 minute over the time. Yeah.
No problem. Thank you very much, Dr. Rupesh, for guiding the discussion. And thank you very much, Dr. Vishali. I joined to Deepa's comments. I think this is a brilliant way to wrap up 2024. And we really look forward to learning from you next year in 2025. We wish you all Happy New Year, and we hope you join us.
Happy New Year, everyone. Thank you.
Thank you very much.
Thank
Happy New Year. Thank you.
Thank you very much.
Happy New Year.
Maybe
Bye.
one quick photo. Can you switch on the video?
Okay.
One photo. Two photo.
I'll take.
Yeah. Just take.
Done.
Thank you so much.
Happy New
Okay,
Year.
thank you, everyone.
Happy New Year. Thank you, Dr. Vishali.
Bye.
Thank you, Vishali. You always learn from you.
Oh, thank
Thank
you. Thank you, Alejandra.
Thank you, Dr.
Bye.
Ho, for joining. Thank you.
All right. Bye-bye.
Bye.